Hi everyone, welcome back to your channel I Love Pharmacology. In this session, let us learn about a very important cardiovascular system drugs, that is anti-anginal drugs. Anti-anginal drugs. So what is anti-anginal drugs? So basically anti-anginal drugs are the syndrome of ischemic heart diseases. It is primarily a syndrome of ischemic heart diseases. So what do you understand by anginal pain? So anginal pain refers to a mismatch between the oxygen demand and the supply to the heart. So there will be inadequate oxygen delivery to the myocardium, and also there will be an inadequate myocardial requirement. So because of this imbalance, because of this mismatch or the imbalance between the oxygen demand and the supply, there leads to the ischemia, which leads to anginal pain. So next we'll move on to the what are all the types of angina. So angina can be classified into stable angina, which is also called as classical angina. So what happens in case of classical angina? So basically the coronary blood vessels will be atherosclerosed. So basically the coronary vessels will have a atherosclerotic occlusion. So this is the atherosclerotic occlusion which will going to reduce the blood flow. So, and this type of angina will occur during the effort or the exertion or during the exercise. So, stable angina is also called as angina of exertion or angina of effort. It is also known as exercise induced angina. So, what is the other type of angina? So, we have vasospastic angina, which is also called as variant angina, and it is also called by a name called Prince-Metals angina. So basically what happens in case of vasospastic angina? So there will be vasospasm, as you can see here, the coronary vasospasm is there. So because of this, there is a decreased blood flow due to the vasospasm. So this is the reversible decrease in the coronary blood flow. So next we'll go through the strategies for management of both the stable angina as well as the vasospastic angina. So basically in case of the stable angina, so your strategy is to reduce the oxygen requirement in by decreasing the total peripheral resistance as well as the decreasing the cardiac output. So basically you are going to decrease the cardiac workload. On the other hand, with respect to vasospastic angina, you are going to decrease the vasospasm by increasing the oxygen supply. So let us see which are all the drugs which are useful for decreasing the oxygen requirement. Basically, these drugs will going to decrease the total peripheral resistance and decrease the cardiac output. So for the treatment of classical and stable angina, we use nitrates, which is a potent venodilator. We have a beta blocker as well as calcium channel blocker. So both beta blocker and calcium channel blocker will going to reduce the heart rate as well as the force of contraction, thereby it decreases the oxygen requirement. Whereas on the other hand, for the treatment of vasospastic angina, we require only the two drugs. Please remember, those are the nitrates and the calcium channel blockers. So why beta blockers are not useful in case of the vasospastic angina, or why beta blockers are contraindicated in vasospastic angina? So as you can see in the blood vessels, if you take a coronary blood vessel, suppose this is a coronary blood vessels will have both alpha 1 receptor as well as beta 2 receptors. So when you give a beta blocker, so what will happen to this beta 2 receptor? This beta 2 receptors will be blocked. So what is the function of beta 2 receptor activation? It is to cause vasodilation. So since the beta 2 receptor is blocked, so now the alpha 1 activity will get predominant. So there will be predominance of alpha 1 activity. There will be exaggeration of alpha 1 activity. This will lead to vasoconstriction. So since already in case of vasospastic angina, there is a vasospasm, upon that if you produce vasoconstriction, the patient may go for other complications. So next, coming to the drugs which are used in the anginal treatment. So one of the very important drugs which are used in the treatment of angina is the nitrates. So let us see how the nitrates will going to produce its mechanism of action. So we have an endothelial cell and the smooth muscle cells. On the endothelial cells, we have a receptors for acetylcholine, bradykinin, serotonin as well as histamine. When these neurotransmitters binds to this receptor which is present on the endothelium, so this will going to activate the nitric oxide synthase. Nitric oxide synthase. So this is the enzyme which is required for synthesis of the nitric oxide from the L-arginine. So on activation of the nitric oxide synthase, so there will be conversion of L-arginine to nitric oxide in the endothelium, and nitric oxide which is produced in the endothelium will be diffused into the smooth muscle cells. So it will be diffused in the smooth muscle cells, and here nitric oxide will going to stimulate the guanyl cyclase activity. So guanyl cyclase activity is to convert the GTP into cyclic GMP. As you know, the cyclic GMP is a secondary messenger. Its main activity is to cause relaxation. So it causes relaxation of the vascular smooth muscles, leading to the vasodilation. So this will lead to vasodilation of the blood vessels. So as you can see here, the nitrates will going to produce the nitric oxide. So nitrates are the prodrug of nitric oxide. With the help of nitric oxide synthase, nitrates will going to release the nitric oxide, especially in the veins. So nitric oxide synthase is predominantly seen in the veins compared to the arteries. So that's why it is a potent venodilator. So once the venodilation occurs, what will be the consequence of venodilation? So it leads to the decrease in the preload. So this decrease in the preload means there will be pooling of the blood in the veins. This leads to a decreased entry of blood into the cardiac system. So thereby decrease the preload, which in turn decrease the cardiac workout, as well as this will going to decrease the oxygen requirement by the heart. On the other hand, very important other usefulness which is produced by venodilation is it will going to decrease the size of the infarct, thereby it will decrease the post-myocardial mortality, post-myocardial infarction mortality. So what are the nitrates which are useful for treating angina? So as we know that we call nitroglycerin or glyceryl trinitrate, it is also called as glyceryl trinitrate. So usually this is given by sublingual route. So what are the other routes through which that nitroglycerin can be administered? So they are transdermal route, IV formulation. They can also be administered in the form of ointment, patches, etc. So on the other hand, we also have a isosorbide dinitrate and the mononitrate. So isosorbide dinitrate is longer acting, whereas nitroglycerin is faster acting. So sublingual tablets are preferred here. So isosorbide mononitrate and dinitrate are given through oral route. It has got extended release formulations where it is useful for chronic use of the angina, for prophylaxis of the angina. So what are the side effects you can encounter when you give the nitrates? So since nitrates causes cutaneous vasodilation, it can cause flushing. So it can cause cerebral vasodilation leading to the headache. Since it causes the vasodilation of the blood vessels, it can cause orthostatic hypotension due to the fall in the blood pressure. Due to the fall in the blood pressure, it can cause reflex tachycardia, and also it can lead to fluid retention. So apart from this, very important side effects that the patient encounters is the first dose, that is the orthostatic hypotension as well as the flushing. So what are the contraindications for use of the nitrates? So please remember, nitrates can cause tachyphylactic reactions. So thereby nitrates should be contraindicated if there is a previous allergic history to the nitrates in an individual. And also it can cause a completely cardiovascular toxicity risk when it is used along with the sildenafil. Please never combine nitrates with sildenafil. So what is the reason? The clinical reason behind not combining nitrates as well as sildenafil is sildenafil, as you know, it is a vasodilator. Again, a sildenafil is also a potent vasodilator. Basically, they are the phosphodiesterase 5 inhibitor. They are the phosphodiesterase 5 inhibitors. Thereby, what is the activity of phosphodiesterase 5? It will going to increase the metabolism of the cyclic GMP. So whereas this sildenafil going to inhibit the phosphodiesterase 5 activity, thereby it will going to increase cyclic GMP. So on the other hand, both nitrates will also going to increase cyclic GMP. If you combine with sildenafil, again it will going to cause increase in cyclic GMP, causes profound fall in the blood pressure due to the vasodilation, and patient may die also due to the hypotension. So that's why they are not combined together. So where do we use sildenafil? Basically in case of erectile dysfunction. So the patients who are on already the sildenafil for the treatment of erectile dysfunction, they should not be given nitrates for the treatment of angina. Is that clear? Fine. So the concomitant use with nitrates, the sildenafil use with nitrates will going to increase the cyclic GMP production. Thereby it increases the nitric oxide. It will cause profound fall in blood pressure leading to the death due to hypotension. So apart from that, one side effect you should remember is Monday's disease. So usually with nitrates, Monday's disease will occur. In case of nitrates, in case of the persons who are working in case of explosive industries, when they come on Monday, what will happen? Monday, after 2 days, there will be vasodilation leading to the pain, leading to the anginal pain. So this will be relieved when the individuals goes for a weekend holidays. On the Saturday and Sunday, there will be divide of exposure to the nitrates. Thereby there won't be any pain or the hypotension. So when they come to the industry again on the Monday, again they will be exposed to the nitrates, and on the Monday it will going to cause vasodilation. This will lead to Monday's disease. So what is the importance of this? You need to give a interval disease or the drug free interval to prevent the tolerance to nitrates. So you need to give a drug free interval to prevent the development of tolerance to nitrates. So what are the other phosphodiesterase 5 inhibitor that should not be combined with the nitrates? So we have a sildenafil, we have vardenafil, and we have a tadalafil, which are longer acting. And also at this point of time, please remember this, even sildenafil can inhibit the phosphodiesterase 6 activity which are present in the eye, and it can lead to blue-green color blindness. So this was about the nitrates. So next, coming to the very important drug, that is beta blockers. So beta blockers are the drug that is used for treatment of angina of effort. That means they are useful in the stable as well as the classical angina. But please remember, they are contraindicated in the vasospastic angina, as it will going to increase the alpha-1 activity in the blood vessel leading to the vasoconstriction, vasospasm. So what are the beta blocker drugs that can be used to treat angina? So we have a propranolol, atenolol, and metoprolol. Propranolol is a non-selective beta blocker, whereas atenolol and metoprolol are the selective beta 1 blocker. So when they block beta 1 activity in the heart, it will going to decrease the heart rate, it will going to decrease the cardiac output by decreasing the cardiac contraction, and also on the other hand it will going to decrease the blood pressure. So altogether it will going to decrease the oxygen demand by the myocardium. So basically it is used for prophylaxis of angina. So what are the conditions where beta blockers needs to be avoided, or what are the side effects that the beta blockers can cause? So it can precipitate asthma in the individuals who are prone for asthma. So it should be contraindicated. Beta blockers are contraindicated in asthma as well as in case of AV block and in case of acute heart failure, and it can also cause sedation. So please remember, again these will be the contraindications. So asthma, AV block, and acute heart failure. So basically, what are the drugs which can decrease the mortality in stable angina, decrease the mortality in case of angina, thereby you can increase the survival rate. So those are the aspirin. So aspirin is an antiplatelet drug. It is given at low dose. Low dose. Low dose means around 40 milligram to around 325 milligram. And we have a nitroglycerin as well as beta blockers. So the three drugs that will reduce the mortality in case of stable angina is aspirin, nitroglycerin and beta blockers. So next, moving on to the calcium channel blockers. So all the calcium channel blockers can be used to treat the angina. So calcium channel blockers are divided into non-dihydropyridines as well as dihydropyridines. Under non-dihydropyridines, we have verapamil and diltiazem. So these drugs will going to block the L type of calcium channel both on the heart as well as the vessels. Whereas the dihydropyridines, that is the example is the nifedipine, amlodipine and felodipine, they blocks the L type of calcium channels in the vessels more compared to the heart. So dihydropyridines will act more predominantly on the blood vessels compared to the non-dihydropyridines. Non-dihydropyridines will have predominant effect on the heart. So what will be the mechanism if the calcium channel blockers, when it blocks the L type of calcium channel in the heart as well as the blood vessels? So on the blood vessels, it will going to decrease the vascular resistance. On the heart, it will decrease the heart rate as well as it will going to decrease the force of contraction. In turn, it will going to reduce the oxygen demand. So this function is almost similar to that of the beta blockers. So all these beta blockers and calcium channel blockers will going to decrease the vascular resistance, decrease the heart rate, decrease the force of contraction, decreases the cardiac output, and thereby it decreases the oxygen demand by the myocardium. So next, coming to the, so one thing you should remember is never combine beta blockers and calcium channel blockers. What is the reason? Because both are depressant, both are cardiac depressant. So it can cause block as well as the congestive heart failure, acute heart failure. So next, coming to the, what are the other drugs which are used to treat the angina? We have a ranolazine. The mechanism of action is, it has got two unique mechanism of action. So ranolazine, it inhibits the late sodium current, thereby decreases the calcium ions inside the myocardium, thereby it will going to decrease the diastolic tension, they decrease the force of contraction, thereby decrease the cardiac work, thereby it decreases the oxygen requirement. On the other hand, it also inhibits the fatty acid oxidation in the myocardium, thereby it will decrease the oxygen requirement. So one negative thing or aspect, a negative thing about the ranolazine is it can cause QT interval prolongation. And since it inhibits the fatty acid oxidation, they are also called as metabolic modifiers. So next, coming to the trimetazidine. So trimetazidine, the mechanism of action is, these are the PFOX inhibitor, that is the partial fatty acid oxidation inhibitors. They are also called as metabolic modulators. So basically the trimetazidine will going to inhibit the partial fatty acid oxidation in the heart, thereby decrease the oxygen requirement. So there are two drugs which can inhibit the PFOX inhibitor, that is ranolazine as well as trimetazidine. On the other hand, we also have a ivabradine. It is also called as a bradycardiac drug. So if they ask about bradycardiac drug, I should tell about the ivabradine. So what is the mechanism of action? Mechanism of action is, it inhibits the funny sodium channels. It relatively selective funny channel sodium channel blockers. So basically it will going to inhibit the diastolic depolarization, especially in the SA node, thereby it decreases the heart rate, decrease the force of contraction, thereby decrease the heart rate and decrease the oxygen requirement. So where are this ivabradine used? Ivabradine are used for symptomatic chronic stable angina. It can be used as an alternative drug for beta blockers. So what are the side effects you can encounter? So it can cause, since it is a bradycardiac drug, it can cause bradycardia and V stands for it causes visual disturbances. It can cause visual disturbances. And I stands for it is a funny channel blockers. Funny channel blockers. So next we have a phosphodil. Phosphodil is a Rho kinase inhibitor. So this Rho kinase is present in the smooth muscles. So it is a Rho kinase inhibitor in the smooth muscles. Thereby, where smooth muscle is located in the coronary blood vessels. So it inhibits the Rho kinase activity in the smooth muscle. Thereby, it decreases the coronary vasospasm. Coronary vasospasm. So what are the other drugs which can be used for the treatment of angina? We have a nicorandil, that is potassium channel opener. We have allopurinol, that is the xanthine oxidase, which is not approved currently. And we have a sulfonylureas, that is glibenclamide. We have vasopeptidase inhibitor like a NEP, as well as the other drugs which can inhibit the even acetyl angiotensin converting enzyme inhibitors. We have a thiazolidindones, that is the pioglitazone and pioglitazones. We have a ditanoate, that is the protein kinase G facilitators. So just to revise, summarize, so we have a anti-anginal drugs. So basically angina occurs due to the imbalance between the oxygen supply and the oxygen demand needed by the myocardium. So you need to either increase the oxygen supply or you need to decrease the oxygen supply. Most of the times you are going to decrease the oxygen demand by decreasing the heart rate, by decreasing the cardiac output, by decreasing the workload. So we have a nitrites. It is usually given through sublingual route. It bypasses the first pass metabolism is bypassed. We have glyceryl trinitrate. So it acts within 1 minute. So we have a beta blockers. Please remember, beta blockers are contraindicated in vasospastic angina. So we have two types of angina. One is the stable and one is the vasospastic. If you classify broadly, we have a stable angina, we have a vasospastic angina. For stable angina, you can go for nitrates, you can go for beta blockers, and also you can go for calcium channel blockers. Whereas for a vasospastic angina, you need to go for nitrates as well as the calcium channel blockers, and they are contraindicated. Beta blockers are contraindicated for vasospastic angina. We have a calcium channel blockers, ranolazine, which is a dual action. One is the sodium inhibitor as well as it inhibits the PFOX activity. Ivabradine, again it is a sodium inhibitor, sodium channel, that is funny sodium channel inhibitor. Trimetazidine, again they inhibit the PFOX activity. Phosphodil, it is a Rho kinase inhibitor. We have vasoactive peptidase inhibitor, that is omapatrillate, which will going to mainly inhibit both angiotensin converting enzyme as well as the neural endopeptidases. We have a nicorandil, that is the potassium channel opener. Apart from that, we also have a sulfonylureas and the allopurinol. So this was all about the anti-anginal drugs. Hope this was clear in understanding the anti-anginal drugs. Very important drug from this chapter to remember is the nitrates, beta blockers and the calcium channel blockers. If you find this video useful, please do subscribe to my channel, I Love Pharmacology, and do not forget to share and hit the like button for more updates on pharmacology. Thank you.